Hi guys, we are going to see about the drugs acting on central nervous system. Basically about sedatives and hypnotics. So why sedatives and hypnotics? Some people have a tough time going to sleep by themselves, especially the teenagers, the depressed ones, and the old age people. So in order to promote the quality of their sleep, we use sedatives and hypnotics. So sedatives and hypnotics. These terms can be used interchangeably, but they have totally different meanings. Sedative is a drug that subdues excitement, calms the subject without actually inducing the sleep. Hypnotic is a drug that induces or maintains sleep similar to normal arousable sleep. Actually, these are global CNS depressants with somewhat differing time action and dose action relationships. Okay, so next, we're going to see about the classification of sedative and hypnotic drugs. So sedative and hypnotic drugs are classified into three classes: benzodiazepines, barbiturates, non-benzodiazepines. So benzodiazepines are again divided into hypnotic, anti-anxiety, and anticonvulsant. So hypnotics may be diazepam, flurazepam, anti-anxiety may be diazepam, chlordiazepoxide, anticonvulsant, diazepam, lorazepam. So barbiturates are classified based on their T-half and they are classified as long-acting, short-acting, and ultra-short-acting. So like phenobarbital, butobarbital, and thiopentone sodium. So non-benzodiazepines, they are zolpiclone and zolpidem. So they are actually called as Z drugs because most of the drugs' names start with Z. Okay, next. Why sedatives? Why actually use sedatives? Like the elderly people and the depressed teenage people have a very tough time going to sleep by themselves. So for them, and for the insomniacs, mostly actually 50% of the population worldwide is affected by insomnia and sleeplessness. So for them, we give sedatives. Okay, and anxiety patients. So they react to a normal situation with high CNS activity. So for them, we give CNS depressants and calm them. So actually CNS depressants are also called as tranquilizers. You know, tranquility means inducing a sense of calmness. So we actually calm the CNS depressant and depress them so that they have a more good quality sleep. So anti-anxiety and sedative drugs are prescription drugs used to relieve anxiety or help with sleep, but their use can result in dependency and a substance use disorder. Actually, this is noted more in case of barbiturates because they are actually classified as substance abuse drugs and are not prescribed now. So prescription drugs used to treat anxiety and induce sleep can cause dependence. So actually the person may be physiologically and psychologically addicted or just psychologically addicted. The person may think that they want the drug to sleep, but they actually don't. Sometimes it also causes physiological dependence. Example, the barbiturates. Okay, next. Benzodiazepines. What are benzodiazepines? Benzodiazepines are a type of medication known as tranquilizers, as I said, to induce calmness. Benzodiazepines are sometimes called as benzos, work to calm or sedate the person by raising the level of the inhibitory neurotransmitter GABA in the brain. So the common benzodiazepines include diazepam, alprazolam, Xanax, and clonazepam. So, the mechanism of action of benzodiazepines. So, the mechanism of action of BZTs. So BZTs act by enhancing presynaptic and postsynaptic inhibition through a specific BZT receptor, which is an integral part of GABA chloride complex. So this BZT receptor is actually present on the GABA chloride complex. Okay. So the barbiturates actually increase the frequency of chloride channel opening at low concentrations of GABA. GABA itself is an inhibitory neurotransmitter worked by opening of chloride channels. So what this benzodiazepines do is that they increase the frequency of opening of chloride channels. So chloride concentrations gradually increase, therefore GABA facilitatory action is taking place. The advantage of benzodiazepines is that they do not open the chloride channels directly, but instead act more subtly by potentiating the effect of GABA. So pharmacological actions of BZTs. They mostly act on CNS, okay? They exert relatively selective anxiolytic, hypnotic, muscle relaxant, and anticonvulsant effects. So BZTs actually hasten the onset of sleep, reduce intermittent waking, and increase the total sleep time. So they're not actually general depressants. Okay, even when apparent anesthetic dose of diazepam is administered in IV, some degree of awareness is maintained. They actually hasten the onset of sleep, okay, and reduce intermittent awakening. So actually the sleep has 4 stages, okay, to say. Stage 1 is dosing stage. Stage 2 is unequivocal sleep. Stage 3 is deep sleep transition or non-rapid eye movement sleep, and stage 4 is rapid eye movement sleep. So what does this benzodiazepine do? The time spent in stage 2, that is unequivocal sleep, is increased, but the time spent in REM and non-NREM stage, that is the non-rapid eye movement phase, is decreased. Okay, they tend to shorten REM phase, but effect is less marked than with barbiturates. Okay, so actually they are less pleasurable. Okay, and another action of benzodiazepines is important to quote here is it decreases nocturnal gastric secretion and prevents stress ulcers. Actually, stress ulcers are caused by increased stimulation of vagus nerve, which also innervates the gastric mucosa. Actually, benzodiazepines, which are CNS depressants, depress and reduce the action of vagus nerve. Therefore, they prevent stress ulcers. Okay, they do not significantly affect bowel movement. Okay, now some degree of tolerance is developed to the sleep promoting action of BZTs after repeatedly nightly use. Okay. And they also produce centrally mediated skeletal muscle relaxation and exert anticonvulsant activity. Next, pharmacokinetic BZTs. There are marked pharmacokinetic differences among BZTs because they differ in lipid solubility. So benzodiazepines are extensively bound to plasma proteins, resulting in a small free fraction which can cross the blood-brain barrier. The more lipid-soluble members enter the brain rapidly and have a 2-phase plasma concentration decay curve, first due to distribution and later due to elimination. So oral absorption of some is rapid, while others is very slow. So absorption from IM sites is irregular except for lorazepam. Benzodiazepines are metabolized in the liver by dealkalization and hydroxylation to many metabolites, some of which may be active. So the biological half-lives of these drugs, okay, those depend, and that is actually long-acting and short-acting. So these biological effect, okay, the half-life has a direct effect for the clinical indications. For example, the long-acting drugs like flurazepam, diazepam are suggested in case of chronic insomnia, short-term insomnia with anxiety, frequent nocturnal awakening, night before operation or dental procedure. But the short-acting, as in case of alprazolam, triazolam, they are given to the individuals who react unfavorably to unfamiliar surroundings or unusual timings of sleep. Like anti-anxiety, you can put it as anti-anxiety because unfavorably acting to unfamiliar surroundings, and sleep onset difficulties. Okay, that is given for short-acting. So this T-half plays an important role in clinical indications. Okay, they are widely distributed in the body, and the benzodiazepines with a long T-half or those which generate an active metabolites accumulate on the nightly use. Their action may then extend to the next day. So actually while giving benzodiazepines, the patients are not advised to driving. The adverse effects are drowsiness, lightheadedness, confusion, unsteadiness, dizziness, slurred speech, muscle weakness, and memory problems. So as I said, they are not advised to driving, and hangover is actually less common. Okay, weakness, blurring of vision, dry mouth, and urinary incontinence are occasional side effects. They can also aggravate sleep apnea. So they should not be given in respiratorily depressed persons, like persons having asthma. They should not be given this. Okay, tolerance to the sedative effects develops gradually, but there is little tendency to increase the dose. The dependence producing liability of BZDs is low. They are weak reinforcers, that is less pleasurable than compared to other drugs. So the drug abusers find this bland and prefer other CNS depressants. So actually the abuse rate is very, very low. Okay, and even the withdrawal symptoms, even if they get addicted, the withdrawal symptoms is generally mild. Drug seeking behavior is not so prominent. Barbiturates. So what do we know about barbiturates? Actually, barbiturates have been popular hypnotics and sedatives of the last century up to the 1960s, but they are not used now, as I said, because of the addictive behavior. However, they are described first as they are the prototype of CNS depressants. Barbiturates are the main CNS depressants, but they are not used now because of the addictive behavior. So what are barbiturates? Barbiturates are drugs that act as a central nervous system depressant. Yes, as usual, barbiturates are effective as anxiolytics, hypnotics and anticonvulsants, but have a physical and psychological addiction potential as well as overdose potential among other possible adverse effects. So barbiturates are substitute derivatives of barbituric acids, that is melonylurea. So lipid solubility of different members differs, and that we'll see in pharmacokinetics. Now, the examples are phenobarbital and pentobarbital. Mechanism of action of barbiturates. The primary mechanism of action of barbiturates is inhibition of the central nervous system. It causes central nervous system depression. This is brought about by stimulating the inhibitory neurotransmitter in the brain called gamma-aminobutyric acid. So we know that GABA receptor, that is the GABA receptor is the main inhibitory neurotransmitter. Okay, so this GABA receptor contains the BZT chloride channel complex and potentiate GABAergic inhibition by increasing the lifetime of chloride channel opening. Simple. To put on simple words, there is a receptor in the GABA channel complex which actually increases the frequency of opening of chloride channels. So this increases the chloride concentration, thereby it has a GABA facilitatory action. So the main action of barbiturates is to facilitate GABAergic transmission, that is GABA mimetic action. Barbiturates have a GABA mimetic action. So we saw benzodiazepines. They do not act on chloride channel itself. They act on GABA receptor. But here barbiturates, they act on chloride channel conductance. Okay, they directly increase the chloride channel conductance and inhibit CA dependent release of neurotransmitters. Okay. Pharmacological actions of barbiturates. They actually shortens time to take into fall asleep, increases sleep duration. So actually sedation, sleep, anesthesia, coma. This is the stages of dosage. So short dosage causes sedation, slightly increase in that causes sleep, higher increase in that causes anesthesia, and very higher increase causes coma. Okay, that is drug-induced coma. Sedative dosage is given to produce drowsiness, reduction in anxiety and excitability. Euphoria is experienced in addicts. Exactly. This is the main reason why this drug is abused. Okay, it has more pleasurable effects than benzodiazepines. It has an anticonvulsant action. It also causes decrease in BP and heart rate. Actually, they have hangover in the morning after nightly dose. The patients may have hangover like dizziness, distortions of mood, irritability and lethargy. Okay, so here the sleep cycle, what it does to the sleep cycle is, the sleep is actually arousable, but the subject may feel confused and unsteady if wakened early. Okay, so there are 4 stages of sleep as we told. Now, here also it decreases the REM-NREM sleep cycle. That is, stage 3 and stage 4 are decreased and disrupted. But the second stage sleep is increased. The effects on sleep becomes progressively less marked if the drug is taken every night consecutively. Pharmacokinetics. So barbiturates are well absorbed from the GI tract. They are widely distributed in the body. Their rate of entry into CNS depends on solubility. Highly lipid soluble thiopentone sodium has practically instantaneous entry. Okay, so plasma protein varies with the compound actually. For example, thiopentone binds 75% to the plasma protein. Phenobarbital just binds 20% to the plasma protein. Okay, so actually phenobarbital enters very slowly. And now the redistribution, it's an important in case of highly lipid soluble thiopentone and other ultra short acting barbiturates. So when we are giving IV injection, the consciousness of the patient is regained in 6 to 10 minutes due to redistribution. This is an important to note. Okay, so after IV injection, consciousness is regained in 6 to 10 minutes due to redistribution. So excretion. Barbiturates with low lipid solubility, that is the long-acting agents, are significantly excreted unchanged in urine. Okay. So now, what are the uses actually? Before adverse effects, I'd like to quote the uses. That is, phenobarbital is used in epilepsy, thiopentone in anesthesia, but barbiturates are seldom used now because, of the addictive behavior. I'm telling that repeatedly because barbiturates are not used now. They are occasionally employed as adjuvants in psychosomatic disorders. So what are the side effects? Yes, as usual, drowsiness, headache, low blood pressure, nausea, sedation, skin rash, and addiction. Actually, there is barbiturate poisoning. So excessive CNS depression. Patient is flabby, comatose with shallow and failing respiration, fall in BP, cardiovascular collapse, renal shutdown, pulmonary complications, and bullous eruptions. So there is also a lethal dose depending on the lipid solubility. Okay. The treatment, is gastric lavage, supportive measures such as patent airway, assisted respiration, oxygen, maintenance of blood volume by fluid infusion, and use of vasopressors. So actually, I told you about the drug abuse, that is psychological as well as physical dependence occurs, and barbiturates actually have considerable abuse liability. That is one of the major disadvantage. Withdrawal symptoms are also present. There are excitements, hallucinations, delirium, convulsions, and deaths have occurred. Why BZTs are preferred over barbiturates? Benzodiazepines and the newer non-benzodiazepine hypnotics are now preferred over barbiturates for most of these clinical uses because they have a wider therapeutic index, tolerance develops more slowly, and their liability for abuse. So yeah, non-benzodiazepines. What are non-benzodiazepines? They are sometimes colloquially referred to as Z drugs and are a class of psychoactive drugs that are very benzodiazepine-like in nature. So this is a newer group of hypnotics that is chemically different from BZTs but act as agonists on a subset of BZT receptors, producing hypnotic amnestic action with minimal anti-anxiety and anticonvulsant effects. The duration of the action is relatively short, because of which they are preferred for treatment of insomnia. Example is zopiclone and zalplon. So the mechanism of action of non-benzodiazepines. The non-benzodiazepines are positive allosteric modulators of the GABA A receptor. Like the benzodiazepines, they exert their effects by binding to and activating the benzodiazepine site of the receptor complex. Actually, the mechanism of action of non-benzodiazepines is similar to the mechanism of action of benzodiazepines. So what we saw in benzodiazepines is that they do not actually act on chloride receptors, but they act on GABA, which potentiates the frequency of opening of chloride channels, and it facilitates the GABA action. That is, the GABA will be increased by acting on the GABA receptor, not on the opening of the chloride channels. So non-benzodiazepines also act on the same way as benzodiazepines usually. See, they are used as allosteric modulators. Pharmacological actions of non-BZTs. So non-benzodiazepine drugs are much more selective than the older benzodiazepine anxiolytics, producing effective relief of anxiety, panic with little or no sedation, anterograde amnesia or anticonvulsant effects, and thus potentially more precise than older anti-anxiety drugs. So adverse effects of non-BZTs. Before that, I'd like to quote the uses. They are actually the most frequently prescribed drugs nowadays. Okay. They also have combined with many other categories of drugs with a view to improve efficacy by relieving the attendant anxiety. They are used as anxiolytic and for daytime sedation. And insomnia arises under a variety of circumstances. It could be long-term, short-term, or transient problem. So, the use of this non-benzodiazepine hypnotics have proven to improve the conditions of the insomniac patients. Okay. Actually, zopiclone, zolpidem, and zalpidem are being increasingly used in place of normal BZTs. So the adverse effects, coming to adverse effects, their non-benzodiazepine sedatives may also induce dizziness, lightheadedness, confusion, double vision, and memory impairment. Other side effects include nausea, ataxia, slurred speech, slow reflexes, loss of balance and coordination, and vertigo. Okay. Actually, no tolerance or dependence has been reported, and hypnotic effect does not fade on nightly use. This is the most important thing, because in case of diazepam and lorazepam, actually tolerance develops, and the patient requires more dosage than the actual dosage given first, and so that is actually a disadvantage. But here the hypnotic effect does not fade in non-BZTs. So, but it actually, the use should be limited to 1 to 2 weeks. Okay. So, the contraindications in all the sedatives and hypnotic drugs. They may cause respiratory depression in susceptible individuals. For that reason, they are contraindicated in people with myasthenia gravis, sleep apnea, bronchitis, and COPD disorders. And of course, you should refer when you're giving this to pregnant individuals due to the teratogenic effects. And mostly because sleep apnea is serious, and you should not give to the patients with respiratory disorders. Yeah. Thank you, and that's all about